thanks to the organizers also for asking me to. The task given to me was to review the literature which is there for Indian scenario in desensitization. And as you all know that there is very little published literature from our country, though a lot of it is being done, but the published literature is very little. And so I'll review some of the published literature from our country and also share some of our experience in this area. So one of the early protocols which came was from the IKDRC, and this was a very paper which was long back in 2011, where they were trying to desensitize highly sensitized patients who were CDC positive. And they used a very complex algorithm. As you can see, it was consisting of bortezomib, MMF, plasmapheresis, IVIG, the rabbit ATG, and then repeat AHG flow cytometric cross matches. If they were negative, acceptable. If not negative, retux, bortezomib, cyclosporin or tacrolimus, and then plasmapheresis, IVIG, repeat the cross match if negative. If not acceptable, then not to transplant. So it's a very long back. This was protocol was there, and this was the first papers to this. So they did about 34 patients between 2008 and 2010. They were all CDC positive. They were able to, with this protocol, they were able to desensitize 29 out of 34 patients. They became CDC negative, and 23 with the first step, which I described, and 4 which actually 6 went to the next step. 4 grafts were lost, 3 to rejection, 1 to infection. And there were adverse events for 2 neuropathy, 1 CMV, 2 UTI, and 2 tuberculosis. So this was one of the early attempts to it using complex protocols. But since then, it has not been replicated later on with this protocol. Then the cases which came from was from Medanta. Dr. Kher actually reported 3 cases. They were all again cases which were actually desensitized. They were all ABO compatible, but they were all CDC negative, in the sense that the CDC was very weak positive T cell here, otherwise they were negative. Flow B cell positive, but T cell negative, except for one which was positive. And they were having the DSA which was positive in each of them. And the MFI titers were not very high. And they used a protocol of using single dose rituximab with a cascade plasmapheresis. So they would do plasmapheresis and check for the antibodies. And the DSA came down to a mean fluorescent intensity of less than 500. And the flow and the CDC were negative, and they would transplant this patient. So they reported 3 cases which are no rejection and normal renal function, at least for the period of observation that they had. Later on, another study came from the same unit. Dr. Bansal reported it. Again, they did actually desensitization based on the results of Luminix technique in the kidney transplant, a single center experience. 12 patients they took, 2 were ABO incompatible also. They were all CDC negative. Flow cytometric crossmatch 4 T cell and 6 B cell, and 2 had both B and T cell positivity. The cumulative MLFI ranged from 1,000 to 10,000, and the mean follow-up was about 26 months to 13 months. So their protocol included plasmapheresis followed by low-dose intravenous immunoglobulin and induction with antithymocyte globulin. Patients were taken for transplant when MFI was less than 1,000 and flow was negative. If ABO incompatible, rituximab was given prior to plasmapheresis, and maintenance consisted of TAC, MMF, and steroids. They had an excellent outcome. Only 1 TCMR, 1 patient had TB, and 2 had UTI. No graft or patient losses were reported in this study. Then there is a study which come from from Dr. Singh. They come from the hospital in Delhi, and they reported desensitization therapy in kidney transplant cases with positive baseline CDC positivity and high donor-specific antibodies. They report a case series of 5 patients, the CDC positive, MFI more than 10,000. Their protocol consisted of using rituximab 14 to 21 days prior to the transplant, followed by immunosuppression was started, which was TAC and MMF. And they also did plasmapheresis all through till the transplant. And then in the peri-transplant period, it was given thymoglobulin was given. And in the post-operative period, they also did some plasmapheresis following the transplant. They reported 5 cases in their series, and they were all the B and T cell cross matches. The T was positive in one, another was B and T positive, third patient both positive, 1 T or B positive and B positive. Flow cytometry was positive in all of these 5 patients. Ritux was used in a dose of 200 and then 500 in other patients. 9 pre-transplant plex were done, and depending upon the requirement, they did 12 or 6 or 8 pre-transplant plasmapheresis. ATG induction was given. A total cumulative dose of about 150-200 milligram was given. And TAC, MMF, and steroid remained the backbone of their immunosuppression. And the creatinine at the time of discharge has been shown here. There was an excellent outcome. They did not report any rejections or anything. I don't know, maybe there's some bias in reporting, because generally People would not report if they didn't do so well. But this is all the data, which is the published data available in our country. And there are one or two case reports not doing well or doing well, but case series are the ones which I have listed over here. So though there has been a lot of interest in it, the published literature is very little. So when they asked me to review the literature, I thought, let me also review what we have done in the last few years. Generally, we do not transplant patients who are CDC or a flow positive, but DSA has been available to us since 2019. And in our hospital, we have been doing DSA for all the transplant patients, pre-transplant single antigen assay was done. So in our patients, we did between 2019 and 2024, we did about 512 living donor transplant. ABO incompatible were 81, ABO compatible were 431, DSA positive were 48. This was any DSA positivity, and DSA positive plus compatible were about 40, and which was a match cohort we had taken. And this cohort we had chosen based on the same time of transplantation and similar characteristics. So, and we analyzed these 40 patients overall. So if you see that the mean age, as you would expect, many of them are young patients. Most of them are males, which is represents our socioeconomic status. And diabetics were equal in both the groups. Dialysis vintage was very short, 11 months and 8 months, because most of the patients who come to our center, they come as soon as they get a diagnosis of kidney disease, and they want a quick living donor transplant. We essentially serve the urban and semi-urban areas of our country. So most of the spousals were about 6 in each of the group. Parents were 21 and others were 13. And retransplants, though they were DSA, was actually in the positive group was none, but in the negative group there were 3. And the pregnancy and blood transfusion are the major reason for DSA becoming positive. So essentially, they were not very high-risk patients. So class 1 was seen in 6, class 2 in 27, and both class 1 and class 2 in 7. The MFI less than 1,000 was seen in 10 patients, that is 25%. 1,000, these were the highest MFI, and they were not the cumulative MFI. And 1,000 to 3,000 in 19, and more than 3,000 in 11. The immunosuppression that we used was no induction was used in 4 patients. ATG was used in 32 and Simulect in 4 in the DSA positive. And the DSA negative, similar immunosuppression, but no induction used in many of these patients in our center. We don't routinely use induction in patients who are DSA negative and otherwise living donor transplant. Desensitization was done using rituximab and plasmapheresis in 9 patients. And otherwise, the mainstay of immunosuppression remained TAC, MMF, and steroid in both the groups. If you see the desensitization, again, the protocol used was to use rituximab 2 to 3 weeks prior to the transplant, do plasmapheresis, and then do a transplant after this. Essentially, most of the desensitization protocol in the country, when I talk to people, they have used it for what they do in the ABO incompatible transplant, because that is what most people are comfortable with. And whenever they see MFI nowadays, everybody has that question in their mind, whether this is pathogenic or non-pathogenic. We have no way to prove. Flow and CDCs are negative. And so there is a risk threshold in every clinician whether to use some form of a desensitizer or not to use. So generally in our center, where it is more than 3,000, they become, because it is a single transplant, very crucial to the patient. So they said, okay, let's do some desensitization. Whether it is truly completely scientific or not is difficult to say, but that's what most would do, is to use rituximab, do 2 or 3 plasmapheresis, use TAC MMF prior to the transplant, and then do a transplant. So if you see, the rejection rates were clinically treated were 4 and 3 in each of the group out of 40. Biopsy proven rejections were 6, 2 were TCMR and 4 were ABMR, and DSA negative, similarly 2 and 2 in each group. And if you were to compare it with the rejections or no rejection in case of, depending upon the MFIs, the rejection rates were not really too different, whether it was 1,000 to 3,000 or more than 3,000. And most of them were treated with steroids alone, ATG, IVIG, and 3 patients were treated with plasmapheresis. And if you see the overall outcome, the creatinine levels were the graft survival. I mean, and the DS and DS negative was nearly similar at about 4 years of the follow-up that was there. And the infections which were seen, which was 8 UTI and DSA positive, CMV in 1, BK in 1. Most of our patients are D plus and R plus. All of them would get venganciclovir for 100 days. That is what our protocol is. BK, we don't do a routine monitoring, but at 2 months, you would run 1 plasma BK levels, because BK doing weekly is too expensive. So we generally would do 1 BK at the time of when we send them off from the transplant center at 2 months, they leave the transplant center. So, and if you see the grafts and the survival has not been really very different. If you see all through, one graft was lost in DSA positive group at 54 months because of ABMR, and another graft in the DSA negative group was lost 19 months because of graft pyelonephritis. So I believe that good outcomes are possible in CDC negative and flow negative, but DSA positive. So though we are doing a lot of DSA, but as has been discussed all through the day, if the flow and CDC are negative, probably that they are at a lower risk and one could safely transplant these patients. So I think I'll end here with there's a positive data from our country regarding HLA incompatible transplant. However, good outcomes are possible in only DSA positive but flow and CDC negative patients. And we need to see if we can also replicate some of the high risk transplant complicated ones that have been reported earlier. Thank you, and I'll end here.